I would like to introduce our guest speaker. We're proud to have Mr. Nick Zucconi, who has served in the Denver Regional Office for over 27 years. Nick spent his first 8 years with the Center for Medicare and Medicaid Services in Denver as the Medicaid Managed Care Program Manager. He then transitioned to the Health Resource and Service Administration in 1997, initially serving as a health center project officer, then coordinator of operational site reviews of the community health centers. Since 2011, Nick has initiated over 60 projects to facilitate linkages and collaboration between HRSA grantees, as well as other federal, state, local, tribal, and private healthcare organizations in Region VIII. Okay, Nick, I would like for you to share your screen and please begin the presentation.
All right, thank you, Marie, and good day, everyone. Glad you're taking the time to spend with me here. I'm going to give you an overview today of the Health Resources and Services Administration, a sister agency of the Indian Health Service within the Department of Health and Human Services. We'll talk about HRSA. We'll talk about the unit within HRSA that I work for, which is the Office of Regional Operations here in Denver. We'll talk a little bit about a couple of grant programs that I think are especially relevant for tribes. And then, as I understand it, we'll have some time for some questions. So very good. As Marie said, I'm Nick Zucconi. I've been with the regional office here in Denver for over 27 years. I started back in 1989 when the first President Bush was in office. And so I'm glad to be here today, and just want to start off by saying and emphasizing that tribal health is one of our priorities here in the Denver Regional Office, and we continue to reach out to tribes and organizations that advance tribal health in order to enable them to take advantage of HRSA's programs. So HRSA is a grants-making organization, and HRSA supports more than 90 grant programs that provide health care to people who are geographically isolated, economically or medically vulnerable, and they do that through grants and cooperative agreements. There's currently more than 3,000 awardees nationwide that have HRSA grants. They include community and faith-based organizations, colleges, universities, hospitals, states, localities, tribal governments, and private entities. And it's important to mention here to reemphasize that tribes are eligible for many types of HRSA grants programs. HRSA, through those programs, is able to serve tens of millions of people, including people living with HIV and AIDS, pregnant women, mothers and their families, and those otherwise unable to access care. Here's a quick snapshot of our funding. This was as of September 2016, a couple of months ago. HRSA has a budget of about $10.5 billion. The bulk of that funding going to, almost half of it going to our community health center program. And we'll talk a little bit more about that. Over $2 billion going to states and community-based organizations to deliver preventative care and primary care to people with HIV and AIDS. We have over $1 billion to both states and community-based organizations, but mainly states, to provide an array of support services for moms and children through the Maternal and Child Health Program. Our health workforce program is unique in that HRSA supports clinical training programs at a multitude of universities and colleges across the country, to some extent including tribal colleges. We have a rural health program of about $150 million that supports both state offices of rural health as well as community-based rural health grants. And those community-based rural health grants are ones for which tribes are eligible, and we'll talk about them a little bit as well. We have a Healthcare Systems Bureau. We are technically the funder for family planning services, although that is the actual implementation and monitoring of that is done by a different agency. We support the Vaccine Injury Compensation Program for people who are injured by vaccines and seek legal redress for that. And then we have obviously a program management line item to pay salaries and just administer the programs. So here's the funding for the last 16 or so years. You can see how the HRSA budget has grown. In 2000, it was a little bit less than $5 billion. And so it's doubled since that time. And you see some large increases there beginning in 2010, and that coincides with funding under the Affordable Care Act. Let's talk about community health centers for a moment. That is the HRSA's flagship program. There's nearly 1,400 organizations across the country that receive community health center funding. Those 1,400 organizations operate almost 10,000 service sites. And again, it's important to note that tribally run health systems are eligible for community health center funding. And as we speak, we have the Utah Navajo Health System, which is receiving health center funding side by side with its IHS funding. We also have, trying to think of any other tribally run clinics. There is another health center, we call them tribal health centers, the Paiutes in Utah again, receive health center funding to augment their Indian Health Service funding that they receive. So it's doable. The only thing to note is that the tribe needs to be running the clinic, as HRSA does not provide funding to another federal agency, in this case, the Indian Health Service. So health centers across the country caring for, in total, more than 24 million people, or 1 in 13 of U.S. residents receive their primary care at one of these community health centers. And statistically, 1 in 3 of those people receiving care at a health center has incomes under 100% of the poverty level. 1 in 6 reside in a rural area. 1 in 10 are children, and 300,000 plus people receiving health care are veterans. So again, the funding in 2016 was a little bit over $5 billion. And note that health centers obviously in place to take care of folks that are low income and that may be uninsured. And so, that obviously is a good thing to do, but at the same time, health centers are delivering quality care. And so if you look at some of the statistics here, 70% of patients in health centers have their diabetes under control, whereas the national average is 54%. 64% of patients have their blood pressure under control, and again, the national average is 52%. And 70%, almost 70% of health centers are recognized as patient-centered medical homes. And then in terms of being efficient with how they spend their money, health centers on average, they have 24% lower total Medicaid spending. That is for people who are eligible for Medicaid and covered by Medicaid and who receive their health care at a health center, on average costs 24% less than does the average Medicaid client. So moving on, we have the Ryan White HIV/AIDS program. And this is a program that provides grants to cities, states, and local community-based organizations to provide HIV care and treatment services. More than half the people living with diagnosed HIV in the United States receive care through the Ryan White HIV/AIDS care program. 83% of Ryan White HIV care program clients are virally suppressed, which is a good management of their clinical condition. And that's up from 70% in 2010. And that exceeds the national average of 55%. Talk about the Maternal and Child Health Block Grant. These are grants to 59 states and jurisdictions to provide health care and services to more than 50 million mothers and children. More than half of all pregnant women benefit in some way from the Maternal and Child Health Block Grant, as do 1/3 of all infants and children, as do more than 4 million children with special health care needs. Between 2000 and 2014, the infant mortality rate has declined 16%, and the child mortality rate has declined by 26%. So as it pertains to tribes with the Maternal and Child Health Block Grant, I note that tribes, only states and jurisdictions, territories are eligible to apply for the block grant. Tribes are not listed as one of the eligible entities. It's a topic, I mention it because it's a topic that frequently comes up during our regional tribal consultations. And so what we try and do here in Region VIII, and we'll talk about this a little bit more in a moment, is create closer working relationships between the state maternal and child health programs and the tribes, such that the tribes can benefit from this maternal and child health block grant funding that the states receive. We have the National Health Service Corps and Nurse Corps programs, and these support over 12,000 scholarship and loan repayment for students in clinical training in exchange for their service in a high-need area. And it's important to note here that the Indian Health Service has a similar program. It's also important to note that both IHS run clinics as well as tribally run clinics are eligible to place National Health Service Corps providers and scholarship recipients in their clinics, and many do so. And so National Service Corps loan repayers and scholars they coexist, they practice at the same sites, as do the Indian Health Service loan repayers and scholars. So the National Service Corps and Nurse Corps clinicians provide care to more than 11 million people nationwide, including over 2.6 million people living in rural areas. We have a Federal Office of Rural Health Policy within HRSA. It provides policy support to the Office of Secretary, hence it's unique in that regard. Within the Department of Health and Human Services, it is the department's federal Office of Rural Health Policy. But it also, relevant to tribes, it also supports a number of rural health programs, grant programs, including ones that can help rural organizations create networks, Black lung clinics, telehealth programs, and veterans rural health access programs. And so we have telehealth grants, and it's important to note there that the Oglala Sioux tribe is currently a recipient of a HRSA telehealth grant. But note that with the assistance of the HRSA Telehealth Network Grant Program, over 3,500 new or expanded telehealth sites have come into existence since 2005. And there's been nearly a 10% increase in the number of sites delivering telehealth between 2015 and 2016. And that we also support what is called a Medicare Rural Hospital Flexibility Program, where HRSA provides support through state offices of rural health, typically, to support rural critical access hospitals are situated in rural and frontier areas to support quality improvement programs by those hospitals. We have a Healthcare Systems Bureau, and the key programs within the Healthcare Systems Bureau is a transplantation program, which helps people register to receive transplants as volunteers for transplants. In 2016, HRSA supported transplantation programs. That is, they supported 33,000 organ transplants, as well as 6,000 bone marrow or cord blood transplants. The Healthcare Systems Bureau also oversees the 340B drug pricing program. It's the program in which drug manufacturers provide discounts to eligible entities that meet the criteria as safety net providers, resulting in almost $4.5 billion saved annually by those safety net providers in terms of what they're paying for the cost of prescription drugs. Here's our organizational structure. Just briefly, you have the Office of the Administrator. Our acting administrator as we speak is Jim McCrae. The boxes on the left and the right of the Office of the Administrator are those offices that support him and the rest of HRSA and the bureaus. And those bureaus along the bottom of the screen there are ones that actually administer the grant programs. So they're releasing the notice of grant, they're releasing the funding opportunities, they're processing the applications, they're administering the process to objectively select who receives funding, and they are likewise monitoring those organizations that receive grants. So moving on to HRSA in the regions. There are 10 regional offices plus an office in Puerto Rico. Relevant to today's discussion is the purple region there, where you see Denver. And so that's Region VIII, and that includes the states of Montana, North Dakota, and South Dakota, which obviously is the home of Northern Plains tribes. The region also includes Colorado, Utah, and Wyoming. So here's our mission. And again, I work within the Office of Regional Operations. And so written into our mission is health equity, to improve health equity in underserved communities through on-the-ground outreach, education, technical assistance, and partnering with local, state, and federal organizations, including tribes. And so I know in Region VIII, we have and continue and will continue to partner with both tribes as well as organizations that advance Native American health, whether it's area health boards such as the Great Plains Tribal Chairman's Health Board, the IHS area offices, and other organizations. We certainly will partner with them to advance Native American health. So again, we're present, the Office of Regional Operations, in our 10 regional offices. And what we do is provide responsive outreach and assistance to HRSA grantees, target populations such as tribes, as well as a range of stakeholders. We partner with and convene local and regional stakeholders to advance HRSA priorities. We're out here, we're closer to states, communities, and tribes, and hence we're able to extend the reach of HRSA's Bureau and Office programs. We represent HRSA at meetings and events to promote the Department of Health and Human Services, as well as the Health Resources and Services Administration, its programs, its initiatives. Hence, I'm here today fulfilling that. And then because of where we're situated, we're able to identify emerging regional and state trends, priorities, and also suggest effective strategies to our colleagues in headquarters in Rockville, Maryland. So looking at it schematically here, these are our core functions. Clockwise, looking at the top left, we have external affairs and outreach. And I think, excuse me, my presence here on your webinar today would be an example of our attempt to reach out and increase people's awareness across the region of HRSA, its mission, its programs, and the Office of Regional Operations. We convene strategic stakeholder partnerships where we engage partners and broker relationships, and I'll give you a couple of examples of that in a moment. Obviously, we have to manage our business, and that's what regional management is about. And then regional surveillance, as just mentioned, given where we're situated, we are uniquely positioned to provide situational awareness to our headquarters with regard to significant trends and activities taking place in the region, including trends and activities that affect tribal populations. Take a drink of water here. So here are our fiscal year 2017 priorities. That's federal fiscal year beginning in October, same as the Indian Health Service. Our priorities this year are HRSA outreach and education. So we're trying to get the word out on HRSA funding opportunities, and I know written into our operations plan here in Denver is getting the word out to tribal populations that tribes are in fact eligible for many types of HRSA funding opportunities. We are, we're collecting data, we're disseminating information based upon who we meet with within the region, within the state, meeting with tribes. Because of where we're positioned, we are situated to help those bureaus and offices that I just spoke of. And so we're representing them at meetings. We're listening to you when we meet with you, and we're passing along your suggestions and advice back to our bureaus and offices. We are engaging with states in that bottom left corner there with state health departments and talking about things to include how can state health departments develop even stronger working relationships with tribes in their particular states. We have a range of special initiatives and partnerships, which vary by region, but in a couple of slides, I'll give you some examples of Region VIII here in Denver's special initiatives and partnerships. And we're also engaging with communities, trying to leverage local organizations, bringing them together, trying to maximize what those local organizations can do collectively that wouldn't otherwise be able to be done by those organizations in separate fashion. So those are our priorities. Here is our team within Denver. We have Captain Deborah Scott, and that right column there, areas of focus. Deb is our Montana state lead, and Deb has done a lot of work relevant to today's discussion with regard to working with tribes, advancing tribal health, working with the Montana-Wyoming Tribal Leaders Council, working with the IHS area office in Billings, and working with the state health department to, again, create partnerships, leverage existing programs, leverage funding within Montana to advance healthcare for Native Americans. We have Kim Patton, who's our regional behavioral health liaison. And to note there, Kim is directing some activities with regard to tribal youth suicide prevention that I believe are mentioned in some of the subsequent slides. We have Captain Christina Mead with the Public Health Service. She is our regional pharmacy consultant, and Captain Mead is currently doing a lot of work on opioid abuse and prescription misuse, and has reached out to tribes to expose them to the work she's doing, to the practices and techniques that she would like to share with tribes, states, communities on how they can limit or prevent prescription misuse and opioid abuse. A new addition to the team is Diana Frick. She comes to us from the Montana Department of Public Health. And Diana is, in Montana, Diana was the program manager for the Maternal and Child Health Home Visiting Program. She will become our Wyoming state lead. Erica Grover is our Deputy Regional Administrator. She is our North Dakota state lead. And Erica comes to us with a background in workforce programs, National Health Service Corps. She has public health background by training. And if you'll note, everyone here in terms of everyone on the team has as their area of focus, tribal health. And so again, just emphasize that tribal health is a priority for our regional office. You'll see that in just a couple of slides. And then myself, I'm currently the state lead for South Dakota. And with regard to advancing tribal health, have worked with, obviously, the Great Plains Tribal Chairman's Health Board, have had the good fortune to spend time with your CEO, Geraldine Church. Likewise, have worked with Nicole Codier, Dr. Giroux, and so I'm fairly well familiar with you folks there at Great Plains. So let's talk about what we're trying to do here in Denver, the regional office, our activities for 2017. One type of activity is what we call HRSA outreach and education, where we are looking to convene grants training workshops. And as we speak, we've started work to develop a workshop in partnership with the Great Plains Tribal Chairman's Health Board, We've tentatively identified in discussions with Geraldine just yesterday, June, in conjunction with a tribal board meeting that it appears Great Plains convenes for the tribes, a workshop, again, to increase tribes' awareness of HRSA grant programs, the grants programs of other agencies within the Department of Health and Human Services, as well as information on some tips on successful grant writing. We envision that to be a one-day event, again, in conjunction with the June meeting of tribal leaders. We provide one-on-one technical assistance. And so there, we're more than willing to reach out to a specific tribe or group of tribes to talk about HRSA funding opportunities, how to apply, et cetera. And then we provide what's called tailored outreach and education. These are projects, partnerships, presentations on a range of topics. And this year, we plan on providing tailored outreach and education with regard to tribal youth suicide prevention, as well as increasing the utilization of diabetes prevention programs and diabetes self-management education programs in rural and frontier areas. As mentioned before, we engage with state health departments, state engagement. And this year, we have a set of activities to develop suicide prevention partnerships with state health departments. We're partnering with states on opioid abuse prevention strategies. We could likewise partner with tribes. We're trying to facilitate the sharing of information between state health departments and tribes, health information for purposes of, again, advancing Native American healthcare. And we are strengthening affiliations this year between the Indian Health Service, tribal health clinics, and other safety net clinics that operate in the same areas of a given state for the purpose of coordination and collaboration. Our community engagement efforts this year, we have 2 of them. We're currently working with a community in Colorado to facilitate collaboration between local health and social service agencies to facilitate a no wrong door approach to services. And we're developing partnerships between providers, community organizations, and public health agencies in North Dakota to strengthen clinic community linkages around preventing diabetes. Our special initiatives and partnerships this year fall under the areas of behavioral health, workforce development, and chronic disease prevention. With regard to our special initiatives on behavioral health, again, Christina Mead is a significant organizer of our Region VIII opioid consultation team. Again, the products and services developed by that team are available to tribes. We are, Captain Deb Scott, working in Montana, is working with the Department of Health and other organizations and units within the Department of Health on a perinatal and infant drug exposure pilot. And there, the challenge is, how can organizations both within the State Department of Health, and external State Department of Health in a given state, how can they collaborate in a way to minimize perinatal and infant drug exposure? And then likewise, we're trying to integrate suicide prevention activities into clinical settings. And so we'll be undertaking a couple of activities in order to try and facilitate that this year. In terms of workforce development, we are attempting to strengthen ties between the state university systems and tribes to increase health career opportunity programs. And so we currently have an active program working with and targeted for the Oglala Lakota. And the idea there is the various health career opportunities programs operated by South Dakota State University, the University of South Dakota, whether it's the nursing school, the medical school, that those programs are, access to those programs is enabled for the Oglala Lakota. So that's a pilot, and obviously we'd like to spread that program, that current partnership to other tribes. We're kind of testing the waters here with a target of the Oglala Lakota. We also we'd like to try and start one of these programs, again, strengthening ties between state university systems and tribes in North Dakota, and we're prepared to do that. We also operate a Veterans Workforce and Training Initiative here in Region VIII. And the goal there basically is to help veterans get employed in HRSA grantee sites, delivery sites, as well as link veterans in need of care in rural and frontier areas to our health center sites for purposes of increasing their access to care. With chronic disease prevention, we are trying to facilitate partnerships between the USDA extension agents and safety net clinics, again, to strengthen linkages between clinics and community-based organizations. I did want to provide, if I could go back here, in terms of our outreach and education, providing information to states, communities, tribes on HRSA funding opportunities. I did want to highlight 4 grant programs for which tribes are eligible, and that I think are very applicable to tribes. And we've had numerous tribes apply for these programs, and I think as years go by, we'll have more successful applicants. But the first of those 4 programs is called the Rural Health Network Development Planning Grant Program. So these are 1-year planning grants, and envision a tribe partnering with 2 other entities, because these are network development grants, partnering with 2 other entities to plan some activity, develop a strategic plan, a business plan, but plan something like that to advance healthcare for tribal populations. In the past, these funding opportunities for planning 1 year have been around $100,000. But this is an opportunity for a tribe to work with a hospital, for a tribe to work with the Great Plains Tribal Chairman's Health Board, again, to advance, to develop a plan around some aspect of healthcare delivery or financing to advance tribal health. That's the Rural Health Network Development Planning Grant. Then we have what is called the Rural Health Network Development Program. These typically have been 3-year grants. Again, tribes are eligible to apply to develop a network with at least 2 other organizations. And these go beyond planning. These are implementation grants. And the key to these grants here is developing a network with at least 2 other organizations to strengthen some aspect of either financing, clinical care, or service delivery in this case, for a tribe. There is the third type of grant we have is called a Rural Healthcare Services Outreach Grant. These are typically 3-year grants, and these grants are for conceivably a tribe could apply. It's recommended they apply in partnership maybe with a hospital, and they can use these grants to either strengthen an existing service that they have or create a new service that currently isn't available to them. And so these are Rural Healthcare Services Outreach Grants. They can do this by forming a network. The difference between these grants and the network grants are that the outreach grants enable the funding, at least in the past, has enabled the recipient, the grantee, to provide a service as opposed to just establishing a network. And the fourth type of funding opportunity that I think is relevant for tribes is called the Small Healthcare Provider Quality Improvement Program. And again, tribes could take advantage of this program and have to strengthen or augment their chronic disease prevention and management programs. Tribes could use the Small Healthcare Provider Quality Improvement Program to augment the funding they receive from the Indian Health Service, their SDPI funding. So they could use it in tandem with that. Or they could use it in tandem with the funding that the service unit might receive to provide SDPI services. And so again, the Small Healthcare Provider Quality Improvement Program is all about funding to help community-based or tribal organizations provide chronic disease prevention and management services. So with that, I will stop there. And again, thanks for allowing me to present to you folks today. And I guess I will turn it back over to Marie to see what's next. Marie?
Thank you, Mr. Zucconi. I really appreciate that presentation and the information sharing that you provided today. First and foremost, I'd like to ask if there's any questions from the participants on the call. You could either shout them out or you could even send them through the group chat, and I'll go ahead and read them for everybody to hear. Okay, well, it looks like I'm not hearing any questions. I'd like to thank everybody for attending today and also announce that there is a link to give an evaluation to today's presentation in the chat box. If everybody would be so kind as to complete the evaluation, we'd appreciate it. And lastly, I'd like to make an announcement for next month's Community Health Webinar Series, which is going to take place Wednesday, March 8th at 1 p.m. Mountain Standard Time, and it is titled Bringing Back the Tradition of Breastfeeding. Once again, thank you, Mr. Nick Zucconi, as well as all of the participants on the call. And I will be sending out the link to the webinar, so you will be able to see all of the slideshow titles. I received a question that asked if everyone would receive copies of the slideshow. So everybody have a great day.
All right, Marie.
Okay, you can just log off, Nick. Thank you so much. That was interesting. And if you don't mind, I'm going to go ahead and share the webinar with everybody.